everyone, and welcome to today's edition of Podcast. Today is Tuesday, May 24th, 2022. I'm Rifat Mannan in California, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston right now. Today, we are delighted to welcome back Dr. Manoj Singh, who is consultant pathologist and former professor and chair of pathology at the All India Institute of Medical Sciences in New Delhi. So today, Dr. Singh is going to deliver a talk on dermatopathology, and the title of his talk is Dictionary of Dermatopathology. I hope this talk would be very useful for the trainees, especially the residents in wherever you are, and hope you will learn from Dr. Singh. And as always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and we will pass them on to Dr. Singh at the end of the session. And thank you for joining us today, Dr. Singh. Over to you now.
Let me just plug on once.
You can start now, sir.
Yes, I am trying.
And then you can make it full screen.
Oh, okay.
Yeah, it's full screen now. Yes, sir.
Okay.
Yes.
Right. Good morning and good afternoon and good evening, depending on where in the world you are. I am Dr. Manoj Singh. I am a pathologist. I work in Delhi, India, and I have been taking a special interest in skin pathology. So while planning a series of talks on aspects of skin pathology, Rifat had a demand, and I felt it might be useful for many of the people who are now starting to take an interest in skin pathology, and perhaps even of some interest to people who already have been involved with skin pathology, to learn a little bit about the terminology. In dermatopathology, there are essentially two schools of management. And depending on who your tutors have been, you will belong to one or the other. One is to make dermatopathology as difficult as possible, and the other is to make it as simple as possible. The desirable, of course, is somewhere in between, but dermatopathology is actually not as difficult or fearsome as some people seem to see it as. The reason why dermatopathology has a bad name is the very long names that are attached with it. Plus the fact, of course, that the skin is right out there in front. So the dermatologists have a huge advantage over other practitioners of clinical medicine, in the sense that, a liver specialist will say, okay, there's something wrong with the liver, I want to do some tests. Whereas a dermatologist can see the lesion, describe the lesion, classify the lesion, say there are seven types of clinical lesions, and classify them. And then it's left to us to sort of try and justify the histopathology of those. So, one very important thing which you must always pressurize your clinical colleague, or if you are doing both dermatology and dermatopathology, put in a description, because the clinical name which you are using or somebody is using may not really mean the same thing as the person who's using it. It may not mean the same thing to you. So always try and get a clinical description. Now, this dictionary, of course, we have sort of made it as short as we could. And incidentally, Dr. Sudheer Arava, who's an additional professor of pathology and looking after dermatopathology at the AIIMS, is unfortunately busy today. He's MD examiner, so he would not be here. So as far as dermatopathology is concerned, let us look at the essential structure of the skin. Now, this itself becomes a very scary thing if you start listing out that the normal skin has got 8 components. Actually, it has several more, but these are the 8 major components. But it's not really all that complicated, isn't it? This is the skin. I mean, okay, fine, there are 8 components, yes, so what? Now, again, many of you would be familiar with most of what I am saying. So it's just a matter of putting it all together and, kind of organizing it. Now, this is on top, the keratin layer, right? Below that is the epidermis. Below that is the dermis. Below that, here somewhere, is the subcutaneous fat. These are the essential layers in the skin. And then in between, you have other significant structures. You have the blood vessels here, naturally, like everywhere else. You have the nerves. In the skin, particularly, you have the glands. You have sebaceous glands. You have sweat glands. You have the hair follicles. So the skin is a little bit different from other organs, but otherwise, essentially, it's the same tissues. So if we look at the normal skin, we see that there is keratin present in a linear fashion on top. The epidermis, the dermis. A little bit of magnification of the same. A couple of terms which you might like to use. You know, the epidermis and dermis are separated by a structure called the basement membrane, which we'll come back to later. Now, the epidermis consists of epidermal cells, naturally. Now, the epidermis itself is divided into 3 or 4 layers, which I seldom remember. The important one here, of course, is the pigmented layer, the basal layer, the regenerative layer where the skin arises. And these are the cells which also contain the pigment of the skin, which is melanin. Now, these, the epidermis and the dermis they fit together. So you have these little protrusions of the dermis going into the epidermis. And then you have these little ridges or knobs which are going into the coming from above, from the epidermis into the dermis. So you have this interplay. You have these pegs and you have these spaces. These pegs are actually not pegs. It's a peg only in a 2D section. Actually, it's a 3-dimensional structure. So this is known as a rete ridge, R-E-T-E, rete ridge. And this is a rete ridge. and this is a retitage, and in between is the structure which is called a papilla, which is a dermal papilla. And this contains a bunch of blood vessels, uh, popularly known as the papillary capillaries. And these two, held together by the basement membrane, are, what constitute much of the protective effect of the skin. The epidermal cells start forming here. They start forming at the basal layer, mature, keep moving up, and eventually they become a old age and they die. And what is left is the keratin. So the keratin also is actually a layer of dead epidermal cells. As I was mentioning, the melanocytes, these are separate cells from epidermal cells, incidentally. What happens is that these melanocytes produce the melanin, and this melanin is transferred by dendritic processes to adjoining epidermal cells. So now if we come to the changes which you can see in the keratin. The normal keratin, which you saw just now. Now this one is obviously very thick. You can make that out. It's very thick, very dense, very sort of, different looking from this. And this, incidentally, could even be the normal keratin in the palms and the soles, or areas where there is pressure. So this could be normal, but if it is seen in a lesion, then this is known as hyperkeratosis, quite obviously, hyperkeratosis. And actually, it doesn't mean too much. It just means that the cells here are proliferating fast. And here, by the time they reach here, they have died, the individual cells have died and they have separated from each other and they are falling apart. Here, because they have matured fast, they have gone through this process fast, this cellular or intercellular dissolution is not as fast as it is normally. So the cells tend to stick together, which is why you have the hyperkeratotic layer. And as you saw in that, in the earlier two cases, you had one which was almost normal, which was, like layers and layers of keratin, and one which was very dense. And then the third one you have here, which is actually in between. It's thick, it's reasonably dense, but not as dense as the second example which we saw. So, in other words, the same process of hyperkeratosis, that is the cells dying out and becoming only keratin but not separating from each other as fast as they should, can result in several patterns of keratin. This is known as lamellar pattern. Lamellar hyperkeratosis, because it has formed a lamella. And this is known as basket weave, for obvious reasons. But they are both, note, increases in the thickness of the keratin. So this is hyperkeratosis, but this is lamellar and this is basket weave. And again, we have a little bit of a dense lamella. Now, another interesting thing which I'd like to mention here, the cells of the epidermis, they start forming here, mature here, and go up there, right? Now, in between, in this process, what happens is that cells which are globular or cuboidal at the level of the basement membrane start becoming flat. They become hexagonal or polygonal. They develop keratin in them. They have junctions in between adjoining cells, right? And as they are reaching the upper parts of the epidermis, these cells start becoming old, senescent, and they start dying out. The process of dying out means that the keratin remains, the intercellular junctions start becoming weaker so that the skin can slough off, and the nuclei start degenerating. The nucleus, of course, decides the life of the cell. Now, if you remember back, I talked about increased rate of replication of the epidermis resulting in hyperkeratosis. So that because that particular component of cell-to-cell separation is not in consonance with the time at which the cell reaches here. A similar process happens to the nuclei. Now here you can make out that these nuclei, these cells have become flattened, and here now the nuclei are becoming pycnotic, the keratin is increasing, and here again the nuclei, because of the fast rate at which this particular epidermis has matured, some of the nuclei have not degenerated totally. Here you don't see any nuclei at all. Here you do see some remnant of nuclei. Now this remnant of nuclei which are present in the keratin layer is known as parakeratosis. So we have seen hyperkeratosis, parakeratosis. And obviously, like anything else in biology, we have a mixed picture. So you have here, you have hyperkeratosis, parakeratosis in between, and another morphology which you will be reading about in some conditions, which is known as alternate hyper and parakeratosis. So you have this parakeratosis here, no parakeratosis in between, alternate hyper and parakeratosis. Similar thing here, parakeratosis here, none in between, and then again parakeratosis here. And this leads at times to some very interesting for us, that is, signs. And this is a condition which you would read about. This is the genodermatosis. And we have here hyperkeratosis. We have nice basket view of hyperkeratosis. All of a sudden, in between, you have this pillar of dense hyperkeratosis. So obviously, what you can conclude is that the epidermal cells underlying this area are different from the epidermal cells here adjoining, because here the cells are not able to separate as fast as these adjoining ones can. Here the nuclei are little bit maintained, so there is some parakeratosis also. And this is a structure which is known as the cornoid lamella. Now, because we are talking about the dictionary, I am not going to mention the condition in which we see this cornoid lamella. But when you see it, it's a very, very diagnostic sign. It's a giveaway. Of course, this particular structure may occur in 2 or 3 related conditions, but the cornoid lamella, if you see, dermatopathologists get very excited. And this roughly is what clinically a hyper and acanthosis will look like. So again, you can make out here that there is this extensive thickening of the epidermal layer. Now, this extensive thickening of the epidermal layer is known as acanthosis. And this usually or most times is associated with hyperkeratosis. So obviously, whatever is happening throughout this epidermal layer. The epidermis cells are proliferating fast, maturing fast, reaching the keratin layer fast, not losing their separation because things are out of sync, and sometimes not losing their nuclei totally. So these things are linked. And as long as you observe these 1, 2, 3 changes, you should be pretty near the group of diagnosis. So there's nothing great, I hope, which you might have understood. If you are able to observe the changes specifically, see what is different and how different it is, you're there. One other thing I should like to mention is a thing known as abrupt keratinization. Usually, when you have keratinization, you also have keratohyaline granules. So this is the granular layer, which we see here on top. And if you don't have a granular layer, this is the basal layer, cells here, cells maturing, and without a granular layer, they become keratin. This is known as abrupt keratinization. And again, if you see this change, then you know which disorder or which group of disorders you're looking at. A couple of other things of interest. Sometimes, this is the epidermis. Sometimes you might see holes in the epidermis. Now, many times holes in a skin section or in any section are due to technical problems. But at times, they have definite meaning. And here you have these regular ovoid holes in the epidermis and counterparts in the keratin layer. You have these holes in the keratin layer. And if you just see a hole, is also known as a tunnel, is actually an indication to the presence of an organism here. This is scabies, and this is the burrow of the scabies, burrow or tunnel of the scabies. So that lives here also in the keratin and can be the cause of very irritating itching. So if you see only a hole or a burrow, you should be a little suspicious and look at that section a little more carefully. So now coming to the epidermis again, as we have already seen, the cells in the lower part are more rounded. They are becoming pinker and larger and more polygonal, and the nuclei are becoming less and less prominent. You make out here? Nuclei are less and less prominent. And the topmost layer is where the pink keratin is also associated with the blue keratohyali. These are granules which you can actually see in the microscope. So this is the granular layer of the epidermis. And this is the spinous layer. And please note this one little cell, which is sitting there in isolation, and it's again, not going with its friends and brothers joining. Here, this cell has got much more keratin, much pinker. It is, in fact, it is a cell which should have been here, but unfortunately it is present here. Now I'll show you why this is important. just to show that granular layer is prominent. Now, if there is a degeneration in the epidermis, then what happens? Epidermal cells are held together. They are held together by structures called the desmosomes. Now, a desmosome is a junction. It's a hemidesmosome on one and hemidesmosome on the other, which join together to form the desmosome. So, when you have, for example, the commonest cause of this is an inflammation. Inflammation anywhere here. Inflammation or some temperature burn or whatever it is. The cells are now coming apart, right? You can make out. This is not the normal structure. Actually, this is much more normal. This is not. Obviously, this is in reaction to something which is happening from below. So the inflammatory cytokines are very, very well known for doing this. And this particular morphology is known as spongiosis. Spongiosis. Looks like a sponge, spongiosis. And here you can make out, because individual cells, adjoining cells are pulled apart, you have these little fibrous connections. Can you see these? These are the desmosomes. So there are some authors who still feel that when they talk about the ultrastructure of the skin, they say desmosome is also an ultrastructural body. Well, actually, it is, can be seen in the ultrastructure, but you can also see it on a routine ordinary section. When you have this kind of spongiosis, you'll have the cells being pulled apart. And there are many other cells in the epidermis, apart from the epidermal cells. And these are specialized nerve endings. You have the Meissner's capsules, Pacinian corpuscle, pressure receptors, and so on and so forth. Different structures for different purposes. Some of them feel temperature, some of them feel mechanical change, and so on. An important cell in the epidermis is the Langerhans cell. Now, obviously, you would have heard of Langerhans cells in tuberculosis and in granulomas. This is Langerhans. And these 3 or 4 types of cells, including the melanocyte, form the so-called clear cells of the epidermis. So when you have, say, 20 or 30 epidermal pink cells, in between you will have 1 or 2 clear cells. So these Langerhans cells are of importance. They are antigen-bearing and antigen-transporting cells involved in the immune process of the skin. Clinically, what acanthosis, which is thickening, will look like. Thickening, this is what clinically it will look like, what we've been seeing microscopically. Right. Now, we saw epidermis and we saw acanthosis of the epidermis. Now, again, if you look at the type of acanthosis, you are also able to derive some meaning out of that. Now, here you can make out, obviously, this is much thicker than it should be. The depth of the epidermis, it's much more than it should be, right? But it seems regular. There's a lot of inflammation going on, and it seems as if the inflammation is going into the epidermis also. But all these rete ridges are about the same size, same depth, regular. Again, regular. Even though, I mean, these are two which are fused together. These are 1.5. This is a single one, but these are regular. On the other hand, you may have irregular acanthosis, in which we have another slide, I think, coming up. Excuse me, in which you have masses of squamous cells, and you may have mixtures. A very interesting morphological feature or a type of acanthosis is this one. Okay. Here you can make out this is regular. Here you make out that as opposed to most of these sections which you are seeing, where the keratin layer is, flat, whatever is happening is below and above it. In this particular example, the keratin is not flat. The papillae are pushing this part of the epidermis up. And this is known as the church steeple appearance. Again, if you see a church steeple appearance, it tells you that there are some specific conditions which you should be looking at. And because this pattern has occurred, this church steeple pattern has occurred, the keratin on top of it also is in the same kind of. When a clinician feels this particular lesion, this would be very, very rough because the keratin also is coming up in spikes. Here again, we have inflammatory cells in the upper dermis going into the epidermis, causing spongiosis here, being present here. Again, indication towards a particular group of diseases. A higher power of what we have seen already. Irregular spongiosis, irregular hyperkeratosis, this spongiosis. At times, a dermatopathologist gets terribly excited because you see the color of these cells. These are all pink because of the highline. These are all pink. All of a sudden, you will suspect that some of the cells in the epidermis are not pink, they are blue. As, of course, this is an extreme example. And these are blue, these are not pink. So where did the keratin go? Once again, a great indication towards a particular type of condition. This blue stuff is virus. It's human papillomavirus. And in between, you have cells which are relatively more normal looking. And depending, I mean, you may have some cases where you have only 1 or 2 cells to look at. And what the papillomavirus does to the cells, of course, we all know. It causes viral warts, it causes other papillomavirus conditions. Some of them actually are also involved in deposition of cancer. Viral wart is the most, is the commonest manifestation. And I'm not showing you a viral wart. This is associated condition known as epidermal dysplasia villosiformis, which is also caused by papillomavirus. It's genetically, possibly, and behavior-wise, different from the viral wart. But the important lesson being, when you are scanning a slide, look at it carefully. If you're seeing some cells are different, these cells are different. No, this is not different. But something is here. Look at it carefully. Maybe you'll see something very interesting. So, clinically, acanthosis, papillomatosis, as I said, papillomatosis, you'll have a very rough feeling. These are the viral warts actually. Now, next to the epidermis is the layer separating the dermis and the epidermis. That is the basement membrane. Now, one basic fact will tell you all the changes of the basement membrane. There is a tendency in some people to see the basement membrane as a kind of a plastic film which separates the epidermis from the dermis. No, it is not that. The basement membrane is actually, it is formed by elements of the epidermis, elements of the dermis, and it's a very, very dynamic structure. It permits stuff to go from below above, from above below, sometimes using the known channels, sometimes by themselves, and it's a dynamic structure. So, for example, here in this particular case, where you have a lot of inflammation here. So, there is inflammation, inflammatory cytokines are there, and the dermis here is not able to perform its usual function of forming the basement membrane. The basement membrane appears deficient. Can you make out that? This is a special stain for the basement membrane. This is a relatively normal basement membrane. It's not there here at all because something is going on here. And again, the same thing. You have a lot of inflammation here. So the basement membrane is not being able to be formed here. And this particular space actually is also of great interest. This is a fairly diagnostic lesion. This is from a condition called lichen planus, which most of you would have heard of. So when you have a degeneration of the basement membrane because of this inflammation, and you have this space forming above this inflammation. Space is called the Max-Joseph space. And the reason it's called the Max-Joseph space is, of course, because neither Max nor Joseph were the first to describe it. It appears that two gentlemen called Caspari and Robinson had already described it, but it became known as the Max-Joseph space. But important thing being that this is a result of basement membrane not being fully formed. So another very interesting feature which you see in a lichen planus, particularly because of this huge inflammation here, it also affects the epidermis, right? And how does it affect the epidermis? It affects the formation and the maturation of these cells. As a result of that, you can make out that this is a small little photo from a lichen planus. The epidermis seems to be roughly kind of okay there. Granular layer is almost not there. There is a lot of hyperkeratosis, indicating that the cells are not separating. In other words, they're maturing very fast, not separating as much as they should be in the process of dying out. Now that dying out, you might go back a few slides and remember I had showed you one little orphan red cell lying in between the pink cells. Yeah. So that is again part of the process of degeneration caused by inflammation. What happens is that all this inflammation which is going into the epidermis is causing degeneration of cells at all levels. And you can in fact make out Here you have a relatively normal epidermis. Now, this cell is degenerating much before it should be. It should be degenerating like this here. It's degenerating here. A halo has formed around the nucleus, which means that the cytokeratin, which was there in the cytoplasm, is becoming into bundles. And this cell, again, you may have one or two cells like this somewhere. Here you have a cell in which the nucleus is breaking apart, but the cytoplasm is okay. And then this roughly is the area of the basement membrane. You can hardly make out any membrane there, isn't it? Because of this dense, tremendous inflammation. And if you compare this with this structure, now this is not an inflammatory cell. This is not a lymphocyte. This is not any of the inflammatory cells. What is it? It has a pink cytoplasm similar to this, right? Now, these are very interesting cells or remnants of cells called Sivati bodies or colloid bodies, in which the epidermal cells in the lower or the mid dermis, instead of maturing and going up like good boys, they degenerate and they fall down into the inflammatory infiltrate, and they form pinkish structures because the keratin has not degenerated, it has remained, the nucleus has died. So it's a small little bag of keratin, a Sivati body or a colloid body. Once again, we come back to our good friend papillomatosis, the church steeple. Could be pointed like this, could be blunted like this. But the important thing is that there is proliferation going on of the epidermis, and the proliferation of the epidermis is causing a elongation of the epidermis. Make out that the epidermis is going like this. Instead of becoming a thick cushion like this, it is going like this. This is more like a cushion. The earlier one which you saw was the church steeple. And once again, we are back at our lichen planus. You can make out here that there is a lot of inflammation in the upper dermis. A little bit of basement membrane-like material you can make out here. Here it's not there at all. It's gone, absent. And some people use the term that the basement membrane is destroyed, but it's fine to use that term. But actually what has happened is it's not formed at all. It is absent. A higher power of the same. Again, showing you, these cells in the lower dermis, which are, sort of degenerating and falling down here, falling down here. These are the Sivati bodies. We've seen this. Now, the other thing which can happen in epidermal cells, apart from acanthosis, is acantholysis. You saw that slide of spongiosis, right? Now, when that spongiosis is extreme, then the cells will come apart. And that extreme spongiosis is caused by 2 or 3 major events. One is where the desmosomes themselves are separated from each other, right? So you have here, desmosomes are gone. The lowermost area of the epidermis, which is the basal layer, is attached because the attachment here is different. Here, for some reason, the desmosomes have dissolved. This is a condition known as pemphigus. And it has a very characteristic, it's an antibody-mediated disease, and it has a very characteristic appearance. As you can make out here, the individual cells lose their attachment to each other, the desmosomal attachment. So adjoining cells of the basal layer may be separate from each other, right? However, they will remain attached at the basement membrane because that junction is not compromised. So you have cells, individual cells standing in rows, a row of tombstones. They are attached at the lower part, separated in the rest of the thing. So this row of tombstones is a characteristic appearance of this. And as you know, the epidermis itself, it's a dynamic structure. The cells of the mid-dermis pull each other apart into polygonal shape. They pull the basement membrane, and the dermis retains its structure because of this kind of tractions from various. Now, if the attachment between two cells is lost, then obviously the cell will no longer have the same structure of a normal epidermis. So, as you see here, the papilla becomes very prominent because the cells which were giving it shape around it by pulling it, they have lost their attachment. So you have the papilla here, but it's obviously looking different from a normal papilla. And this is also been given the name of a villus. You would remember that a villus is a small little protrusion, usually described in the intestine. In the skin also we have villi. So these two appearances of a dermo-epidermal separation, a row of tombstones for individual cells, and presence of villi is fairly indicative of a particular group of disorders. A row of tombstones. The same kind of thing present inside a polyp. This is a condition known as pemphigus. The cells are separating. Now you see here, these are normal looking cells, and here the cells are separating from each other because they have lost their connection with each other. So these cells are much bigger, polygonal, pulled out. These have become much smaller, these guys, because they have lost the pull of adjoining cells. Similarly, if the basement membrane itself is destroyed because of immunological reasons, you have a dermoepidermal cleft. But in this one, there are no epidermal cells present at the lower part. You can make out this. No epidermal cells. And the entire epidermis has gone up, and the dermoepidermal bulla is in between. This is an immunological destruction of the basement membrane material itself. This is also a bullous condition known as bullous pemphigoid. This, as you can make out, is almost a normal basal layer in appearance. These are cells which are known as, actually, this is not a normal skin. This is a cancer, which is differentiating towards skin. And you can make out that these cells, the cells in the periphery, they have lost their connection with the dermis because, again, as I told you, it's an interaction. And when there is an interaction, the basement membrane does not form as well as it should. The other thing which you can make out is that these cells are in a different orientation from the other cells, right? These cells are elongated. They are vertical, as opposed to these who are lying haphazard. This is known as a palisading appearance. And wherever you have cells which are or a tumor or a lesion which is derived from or deriving from proliferating basal cells, you may have this palisading appearance. Thickening of the basement membrane may occur due to antibody deposition. Can be demonstrated by special stains. Deposits may occur. And coming below the basement membrane, one region which you might like to keep in mind is the top few millimeters of the dermis. It is structurally and functionally different from the rest of the dermis. This is the so-called Grenz zone, G-R-E-N-Z, Grenz zone. And especially when you have light damage in sun-exposed parts, you have a degeneration of the uppermost part of the dermis. So you can make out that this is no longer the nice pink collagen which you usually see. And when you do a special stain, you can make out that the collagen structure is breaking up. Show you in another case. You can make out here normal collagen and hyalinized collagen. Again, the same, a special stain showing you normal and absent or deficient or problematic. Now, this is an elastotic stain called a VVG, Verhoff Van Giesen. And you can make out here that the elastic fibers here are relatively normal, absent. Again, these could be some congenitally derived conditions, or it could be light damage. Very glaring example of elastotic degeneration of the epidermis, giving you these dense cushions of dead elastotic material. Sclerosis of the dermis has multiple reasons. We discuss about these in some of the subsequent sessions. One interesting degeneration of dermis you might like to keep in mind. What we saw just now was sclerosis, elastotic degeneration. So something else is happening here. There is dermis. There is a granuloma here. There is a giant cell here. There is a giant cell here, right? And these giant cells are actually not present in the classic tuberculoid granuloma appearance. They are going in between the collagen bundles. This is known as an interstitial granuloma, right? And this is in reaction to the dermal degeneration. Make out here, the dermis is degenerating and the granuloma is forming in reaction to that. Now the other structures, the hair follicles associated with the hyperkeratosis, and obviously when the hyperkeratosis is occurring inside a hair follicle, and that follicle itself will get distended. It will become wider. Blood vessels, we will not go into too much detail here because this is whole 2 or 3 chapters in itself. Suffice it to say that there are 2 or 3 categories of blood vessels in the skin. There is usually a terminological difference between what pathologists see and what dermatologists speak about. Now, this is a capillary, right? This capillary wall is degenerated. There is inflammation around it. There may be a little bit of, RBC sprinkling here because of leak from here. So this kind of immunological capillaritis is a particular type of disease, leukocytoplastic vasculitis. Now, this same kind of appearance may appear in the in the medium-sized vessels or in the larger-sized vessels. There may be deposits of certain materials, thickening, and or thrombosis. We are not, again, showing you pictures of this that will come out together too. Now, this is an organizing thrombus inside this vessel. This vessel, the medium-sized vessel, developed a thrombus, and now that thrombus is getting reorganized. A deposit, amyloid deposit around the blood vessel. A follicular plug with a lot of hyperkeratosis, parakeratosis, same thing. A sweat duct apparatus. Again, this is a hair follicle, the lower end, sweat duct. And the importance in these, of course, is that at times, because of lesions here, the sweat duct gets obstructed and then gets dilated. So blockage may occur, causing dilatation. Then there is a whole vast scenario of different types of inflammations of the skin. You have already listened to some of them. Perhaps we'll be coming up with some more after some time. This needs a little more careful and longer treatment. So acute inflammation, chronic inflammation, mixed inflammation, granulomatous inflammation, granulomatous with necrosis, and so on. These are, things which need a little. And, different types of inflammations, chronic, lymphoid end. Actually, a lymphoma could mimic as a inflammation. The lowermost part of the skin is the subcutaneous fat. Now, the subcutaneous fat itself may get involved, and essentially, there are two types of paniculitis, which is fat inflammation. One is lobar, where the entire lobe is involved, and one is septal. Now, this is the septa. It separates different lobes of the fat, and you have a lobe here which is relatively uninvolved, a lobe here which is relatively, little more involved, and then this is the septum. So this can be used to distinguish certain types of paniculitis. Now, I wonder how many of you are awake and how many of you think this is of any relevance. Now, this, let me tell you, like prehistoric man, or maybe man had not developed by time, not even man. This is one of the biggest enemies of a dermatopathologist. This is a saber-toothed tiger. See that? Its counterpart in modern day medicine. Oh, sorry. This is the lesion that the saber-toothed tiger caused. This is an hourglass deformity. And this is caused by the tooth forceps. The tooth forceps itself it's a very dangerous thing because it makes the process of taking the biopsy simpler, but it at times causes the most unbelievable artifacts possible. I have a separate talk on artifacts, and in fact, a separate talk on these crush artifacts. This is what can occur because of injudicious use of a tooth forceps. This is the epidermis. This is some part of the dermis. There is inflammation. That's all you can say. You cannot make any diagnosis in this. So always stick to plain, simple forceps. Maybe even use a needle that will leave only a hole. Try and avoid brute forceps. Thank you. Rifat, that's all from me.
Thank you so much, Dr. Singh. So this is a very illuminating talk on so many basic concepts, and as you said, the dictionary of dermatopathology. And there are a few questions that I see online, and one question I would say is that how do you differentiate pilar cyst from epidermal inclusion cyst? So I think something that we're going to love.
I avoided that. Let me ask you a question back. How do you distinguish an epidermal cyst from a sebaceous cyst?
Oh,
Whoever has asked that question.
right.
See, these a pilar cyst is what I've shown you with that abrupt keratinization. An epidermal inclusion cyst is an epidermal inclusion cyst. If an epidermal inclusion cyst has a sebaceous gland opening into it, then it is a sebaceous cyst. So these are, except the pilar cyst, which is a histological curiosity, epidermal and sebaceous cysts are actually overlaps, in the sense that you have a 1 centimeter cyst, you take a section from it. You may not get a sebaceous gland there. You get multiple sections from it, maybe you will get a sebaceous gland. So that's not of any great importance clinically, that is. Yes, it may certainly cause deformity. It may cause, may be taken out for cosmetic reasons, but there is no great reason to distinguish one from the other Pilar is the one which has the um, that other keratinization at abrupt.
But I think so. So if there is a, so this is like if there is a cyst in the scalp, and you see that abrupt keratinization with loss of granular layer, so are you going to call it a pilar cyst, or you're going to call it an epidermal inclusion cyst?
I have no idea. I want to see the slide first.
Okay.
Actually, I have a very interesting slide in my pocket which I have to show around. Again, a cyst which was taken out, and it's got a normal epidermis. Now, I don't know which side was which, because we got just a section, but it's got the normal epidermal keratinization, keratin, and there is a huge thick band outside. I don't know what that band is. I don't know whether this is an epidermal cyst or it's a pilar cyst or it's one of them, because we don't know which is the inside and which is the outside. So we have to, maybe I'll show you pictures next time I come.
Yeah, no, sure, sir. But I think, as you rightly pointed out in your early part of the talk, that one needs to differentiate between the abrupt keratinization that you see, which you have said that you call it tricholemmal type of keratinization, right? So maybe like it has at least some clinical relevance or histologic relevance, in the sense that if you have a large lesion in the scalp, so we have this called like proliferating tricholemmal tumor also, right? So that in that situation, you know that histology maybe.
Refer, now we are going into somewhat gray zones. We have till now talked only about cyst. Now, cyst is something which has been present for some months or some years. When somebody is combing their hair, it causes this thing, they say, it's bothering me, take it out, right? If you start talking about tumors, then tumors is a very, very, very complicated issue. Distinguish tumors one from the other. For example, tricholemma. If it's a plain and simple tricholemmal cyst, then it's a cyst, it's out, it's gone. If it is a tricholemmal tumor, then definitely you have to look at it carefully, decide what type of a tumor it is, what its potential is, whether it can grow back, whether it needs to be excised, and so on and so forth. So that then becomes an altogether different kettle of fish.
Right, right,
So that is why I was actually
right,
deliberately avoiding taking even the disease names.
right.
I was just sticking to defining the morphological changes and avoiding the diseases.
So, sir, there is a follow-up question from the viewer who asked the question on differentiating these two types of cysts. So, but the question is that the viewer wanted to know what is the cytologic difference, not the histologic. Is there any means on cytology to differentiate between pilar cyst and epidermoid cyst? That is the question.
I just showed you, I mean, I can count, but between 100 and 150 different types of cells in my presentation, right? How will you distinguish? A cyst, a pilar cyst, has lining in it. Let me just see. We had that cyst somewhere, didn't we? Where was that? Abrupt. What did I get a? Okay, there you are. Now, I ask you, hold your hand like this, right? Hide the keratin. What is the cytological difference between this normal skin and epidermal inclusion cyst? Don't see the upper part of the lesion. That is the the left side, where there is keratin.
It's the
What do you
lack
think?
of granular layer, is it?
Huh?
Is it
There is
the
lack of granular layer. There I agree with you. Yes, there is lack of granular layer. In this particular one, granular layer is absent. But then again, when you're talking about cytology, granular layer doesn't make cytology. Granular layer is granular layer. In cytology, you mean the cytology of these cells, right? And these cells are the same as the cells of the normal skin. So I would, when you use, in other words, cytology and histology are not different disciplines. They are very, very closely linked. And what is in cytology, you will see in histology. What is in histology, you will see in cytology. And it's a question of making up your own concepts. But as far as this particular case is concerned, you can see yourself, it could be normal skin.
right?
If you ignored that little bit, of course.
Right. So there is another question for you, Dr. Singh. Let me read it for you. One of our viewer asked that dermatitis and inflammatory dermatosis, are they the same or they are different?
Derma is skin, itis is inflammation, right? Inflammatory is inflammatory. Dermatosis is a condition of the skin, right? So quite obviously they are, exactly the same thing. There is no difference between the two. Dermatitis, inflammatory dermatosis. The only difference which I can kind of think of is that you see some little bit of inflammation, and I say, okay, there's a little bit of a dermatitis there, right? That is inflammation of a part of the skin. And if somebody is talking about inflammatory dermatosis, that means that this is a condition of the skin which is caused by inflammation or which has a major component of inflammation. Now, I would hesitate to, kind of play around with these two words. At times English can be a very scary language.
Right.
Anybody can make it mean whatever you want.
Right. Thank you. So the next question is, one of our viewer is asking uh, that how can you elaborate between suprabasal cleavage plane and subepidermal cleavage plane? I'm not sure exactly what's the question.
Say it again, supradermal.
Suprabasal cleavage plane and subepidermal cleavage plane. So can you explain that a little bit more?
Okay, you ask for it, buddy, you get it. Where am I? Where am I? Okay. Actually, I'd shown you uh, uh, these slides I had shown you. Epidermis, everybody can see this?
Yeah.
Epidermis here, bulla cavity here, and then a little bit of dermis here. Dermis is out of this section. This is a dermo-epidermal section with thing in between. The entire epidermis has come out here. Okay? On the other hand, what we had seen about this one. Okay? So this is suprabasal because this is the basal layer, right? Basal layer that I had shown you. This is the basal layer and it is attached to the basement membrane because the attachment of those cells to the basement membrane is different from the normal desmosomal. So desmosomal junctions are gone, but this is attached. So the basal layer remains with the lower part, everything else goes up. This is suprabasal. Is that clear?
I think that is perfect. Yes, sir.
Again, uh, um, uh, not a good photo. Right. Other questions?
Yeah, you can get back to the what's it called, PowerPoint, or you can stop sharing, Dr. Singh. Yeah, that's good. Yeah.
That's right.
So one question is, how do you differentiate between artifactual split and the true split, especially in the subepidermal layer?
Again, you ask for it, you get it. Now, Rifat, now this particular thing is on you. There we are. I have a talk prepared on artifacts.
I think we should do that for sure.
Should I start now?
No, sir. We have to practice another day.
But it's a difficult decision at times because and especially the last slides which I've shown you about the forceps artifact. The forceps artifact itself may cause tearing and pulling apart of the section itself. So it's a difficult thing, but definitely once you have something clear in your mind about the biological plane, what was asked earlier about suprabasal versus dermoepidermal. Now, if you're seeing that, then you're seeing it. If you're seeing something which is at level, one very simple thing which may be difficult to implement is if you're seeing split at multiple levels. At some place it is here, some place it is inside the epidermis, some place it is going, splitting the dermis apart, then you feel that it may be traumatic for whatever reason. but otherwise, it at times may be difficult.
Right. So regarding this same question, I mean, the previous question, our viewer wants to know further from you that so in subepidermal cleavage plane, so is the basement membrane gone? So
Yeah.
so that's the question. That is the basement membrane gone in subepidermal cleavage?
Not necessarily.
Yeah.
The basement membrane itself, it's a complex structure. It has a multiple layer structure. So whatever the antibody which is acting against a component of the basement membrane and causing its destruction uh, may not act. You see, inflammatory cytokines are big shots. When there's inflammation and the cytokines which leak into the adjoining area, they destroy everything. So there is no logic in their destruction. On the other hand, when you have a particular directed antibody which is destroying one particular part of the basement membrane, then it's entirely possible that the other part may remain. And yeah, okay. Uh, as opposed to the pemphigus vulgaris, where there was a suprabasal cleft, can you make out here that this part of the epidermis is relatively nice looking? It's split. It doesn't have a dermis below it, but it's intact. It's viable. And by special stains, you can always show these things off. Same thing here. You can make out that the upper part, the epidermis, is actually the cells are not falling apart. They are being held there by some component of the basement membrane. And the split has happened here. This is inflammation and the bulbar cavity. So at times you may have, you may be able to make out. And in pemphigus, the whole thing will be frayed on both sides because the cells are themselves separated.
I think those are the questions that we got from our viewers, Dr. Singh. You might as well stop sharing the screen if you don't mind. Uh, so you'd be happy to know, Dr. Singh, that we had quite a few hundred viewers who joined us from different parts of the world. And I actually tried to keep track. So those who mentioned where they are viewing from. So we had viewers who joined from as far as Croatia, Ukraine, Pakistan, Greece, Myanmar, Algeria, Argentina, Libya, Madagascar, Peru, Egypt, Tanzania, Hungary, Nepal, India, and there are viewers from US as well. And thanks a lot to all our viewers for your support. And thank you, Dr. Singh, for this excellent talk. And we will continue and we will make a plan when we have the next talk on Dermpath. And our
Sure.
next lecture is coming up. That is on June 7th. So it's going to be a talk on uh, placental pathology in COVID-19. And our speaker will be Dr. Jacqueline Watkins, so who is an assistant professor at Harvard Medical School. So that would be at 9 a.m. Pacific time. And hope to see you then. And if you like our lectures, don't forget to subscribe to our YouTube channel and also follow our Facebook page that is Pathcast. And you can go to our website where all the lectures are arranged subject-wise. And thank you again, Dr. Singh, so for your time and this excellent talk. Thank you.
My pleasure, Rupert.
Thank you.